Thanks to the chair. As To just said that you are the captain of the ship, I think that's the right statement. That as ENT surgeon, as the surgeon who is doing the surgery, the primary responsibility of the patient's safety and the end result is of the surgeon. Though it's a teamwork, but the primary responsibility lies with the surgeon, and that's the fact that we should never forget. But along with that, obviously, it's like this organization of this conference, it could not have been done by one person. It has to, there's a team of people who are working, and that's why it's happening. Similarly, OSA surgery is also a teamwork. It cannot be done by one person. It cannot be done by, just one department of a hospital. It has to be interdisciplinary. In this teamwork, sometimes one has to bow down, and sometimes one has to climb. So the person who is bowing down should not feel inferior. The person who's climbing should not feel superior, because ultimately it's this fitting the things in right place is what matters, and that will bring you the success, and that's the key to success. So for a successful surgery, who is the person whom you require to push you up? I think the most important person in the entire process is your anesthetist. If your anesthetist does not understand what you want, what is the patient and how he can do a safe intubation, extubation, you cannot rise up and do a good surgery. It's just impossible. So you are riding on your anesthetist's shoulder, and this you should never forget. Requirement to do OSA surgery: you should have a well-equipped operating room. You cannot do this kind of surgery in ill-equipped nursing home or ill-equipped operating room. Sorry to say, I mean, it might look bad to hear, but our country has various kind of setups, and we in ISSA guidelines have actually come out with the minimum criteria to do this kind of surgery, and I think we should be very stringent on those criteria, because otherwise the surgery itself, which is now in a very growing nascent stage, will get a bad name. So you should have a sufficiently equipped operating room. Since this is all endoluminal work, so most of the times you require a very, very good endoscopic system. That is at least a must, that you should have a good endoscopic system to do endoluminal work. You should have a facility for a post-operative ICU care if you are going to do, say, tongue base. Yeah, you're not able to hear me? I'm loud or I'm... Okay. Volume, please. Yeah. So you should be equipped with a post-operative ICU care unit if you are doing tongue-based surgery work, especially large tongue-based cases. You should have a ICU. You should not be doing these cases just without proper ICU backup. And your team has to understand your thought process. If your team does not understand, if you're not able to communicate your thought process to the team, then it's going to be really difficult. So if you have to disseminate your thought process, first you have to sit and plan and think, and a detailed planning of every step has to be done. That starts with consultation. You should be consulting your patients yourself, and you should not be relying on a junior doctor to take history, and you should be sitting with the patient, spending some time with them to understand what is their problem, and just by the history you can anticipate many things. Though we all need know about Epworth Sleepiness Scale and Stop Bang questionnaire, but questionnaires and scales really do not tell you too much. Your patient tells what is his problem, and when you are talking to the patient, and examining the patient yourself, doing the clinical examination, doing your sleep endoscopies yourself, you understand a lot about the patient's anatomy and thing. In the guidelines, we have said that you have to do a sleep study, at least a level 3 sleep study, which is properly done. If you do a level 3 sleep study and the patient has not slept, and there's no apnea, hypopnea, which is one of the biggest limitation of this level 3, then you are underestimating the patient too much. The patient may have AHI of 70 and you are seeing it as AHI of 20. So you have to understand your sleep studies, you have to go through them. At least you should be able to understand where you can falter if you read them wrong. Then the airway is through the nose. This is the airway. So to follow the airway, you require a flexible. So any centers, in last 2 days also, some people have been asking me, we do not have a flexible, what do we do? Sorry, if you are operating on these patients, you have to buy a flexible. There's no question. You hire it, you buy it, do whatever, but you have to have a flexible, because you are operating on the airway. You are taking risk on the patient's life. So you have to understand the airway, and drug-induced sleep endoscopy, or at least awake fiber optic examination to see the size of the tongue and collapsibility and blah blah. You must assess the airway yourself. You do not depend on the recording done by somebody else, because especially in sleep endoscopy, how much is the sedation given? Was it adequate? Was it over sedated? You have to present at all the steps of the patient's management to anticipate where things can go wrong. Preferably, you can know the palatal phenotype, pattern of collapse, then is your job. Unless you understand, anticipate the difficulty, you will not be able to take a decision, okay, in what setting. I'm sure all of us are working in more than one kind of settings. One may be a corporate or a big hospital or a small place, with the different. So if you have to take a decision, okay, what is the setup, what is the who is the anesthetist, and what kind of case I'm doing, what is the post-operative care required, you have to understand yourself. So what is one most investigation, if you ask me, to anticipate difficult intubation? It's not Mallampatti or Friedman. It's your drug-induced sleep endoscopy. This was, Mallampatti and Friedman was good till around, say, 10 years, 15 years back. Now with drug-induced sleep endoscopy, we exactly see the airway where it is going to block. And in the next few slides, I'll give you some important observations that I had. And a true view laryngoscope, which Dr. Kalpesh has already talked, is a must if you're doing OSA surgery, because you will keep on getting situations where intubation is going to be difficult. Fiber optic awake intubation should always be available, LMA and simple nasal airway. I think Kalpesh has already talked about it. Now, this is the concept that I have developed over years, the concept of upper segment versus lower segment. Nose and palate are the upper segment of the upper airway, and base of the tongue and the hypopharynx epiglottis is the lower segment. Typically, we are taught to think of AHI as the biggest indicator of difficulty of intubation, surgery, extubation, post-op. Actually, it is not. We showed you in the panel, we showed you cases where the AHI is 70, 90, but the problem is only in the nose and the palate. The base of the tongue epiglottis is normal. So in those cases, the moment you place a oral airway, you are bypassing the nose and the soft palate. So even if the nose is completely blocked, even if the soft palate is huge, large, but the tongue is not big, the epiglottis is not big, you put the oral airway and that upper segment is bypassed. So with the AHI of 100, this patient you can still ventilate very easily. And while extubation, if the nose is not blocked, whatever surgery you have done on the soft palate, you can extubate this patient very easily, and if required, you can put a small airway for some time. So this is a very, very important concept to understand the upper segment and the lower segment. AHI is not the criteria. If you have a problem in the lower segment with a AHI of 30, 40, it's going to pose a lot of difficulty while intubating and extubating, as against a patient of AHI 100 with an upper segment block. So this is one thing that you must understand. Now, this is about the nasal. I think Songtar has already talked that you put a nasal airway which goes till here. If the nasal passage is open, then the patient does not need to breathe through his mouth. If it does not breathe through his mouth, his tongue will not go back and block the posterior pharynx. Now, the second concept is of understanding the lower segment in a better way. So you have to differentiate between the anterior two-third of the tongue and the base of the tongue. When we say tongue, anterior two-third behaves absolutely differently from the base of the tongue. When we see Mallampatti, we say Mallampatti 3-4 is difficult intubation. So why it is difficult? Mallampatti, you cannot see the base tongue. You are only seeing the anterior two-third of the tongue. So why the intubation is difficult? Because the surgeon will, because the anesthetist is not able to view, the line is not like that. So when the anesthetist is going to view the larynx, he is looking like this and trying to intubate like this. And then he is relying on a direct line to be able to see the larynx and then put in the tube. So if the anterior two-thirds of the tongue is big, if the anterior two-thirds of the tongue is big, he'll not be able to view the larynx. That is the only problem. If the base tongue is not big and you have placed a nasal airway or an oral airway, you will still be able to ventilate the patient. So you will not be in a situation where you are not able to ventilate and you are not able to intubate. You may not be able to intubate, but still you will be able to ventilate, and that's not a life-threatening situation. But if the problem is in the posterior one-third of the tongue, then your patient is neither getting intubated nor getting ventilated. And that's a life-threatening situation. So this you have to anticipate by doing a drug-induced sleep endoscopy beforehand. So this division is very, very important, because situation is like this. Your tube is not going straight. It's going like this. So your vision is difficult. So once we understand that the base tongue is not big and only the anterior two-thirds of the tongue is big, then the problem is only angled vision. So this angled vision can be solved very easily by TrueView 45 degree, which by TrueFarTech, which Dr. Kalpesh already mentioned. He introduced me to this scope, and now wherever I do a sleep apnea surgery, he has one, I have one for my own hospital. I buy it wherever I am doing a surgery. They have to keep this, because this makes life so easy, because you are not looking straight. You are putting the scope and you are looking at an angle. And we use 45 degree angled sinoscope to operate on the base tongue. In robot, we use 30 degree upturned scope to view the base tongue. So if you have an angled vision, which is 45 degree turned, the visualization of the base tongue and the epiglottis is much, much easier. So this is the animation showing how it works. Sorry. Got hung. One second. So this is how it works. The anesthetist is looking straight, but the vision he is getting is angled. So the tongue which is there does not come in the way, and he can circumvent the tongue and see the larynx and put in the tube. Now that was animation. This is actual surgery. If you see here, this is actually Dr. Kalpesh's video, which I have hired. So you look inside, you can see the larynx so well, and then under vision, without traumatizing the larynx cords, you can intubate the patient. Now when you are doing a tongue-based surgery, now see, this is the nasal intubation. It's a big tongue. Now he's trying to intubate. That's the soft palate. Tongue is pretty big, so he's trying to negotiate. But see, the tongue is so big, it's falling on the epiglottis, but still he can see the laryngeal inlet, and without traumatizing, one can intubate. So I think this is the key, because what will happen if you're trying to look into a straight line and you are not able to see, and you try pushing the tube, you are not able to ventilate, you are not able to intubate, and you have created bleeding. Now your patient is already relaxed. At least with succinylcholine for 2-3 minutes, he will aspirate the blood. You are not able to see, your field is all red, and now you are in a desperate situation. So this is the key to do OSA surgery. You have to have facilities for proper intubation, so that you do not do a traumatic intubation. There should not be any bleeding into the airway. Same way, while you are extubating, it's very much possible to keep the laryngoscope, lift up the tongue, and then gently extubate. But most of the times, if you have done a tongue-based surgery, you have already reduced the volume of the tongue. You are seeing your criteria of anesthesia gas monitoring, which Kalpesh has already explained, and BIS. AGM and BIS are the two most important things that are required for OSA surgery, and there's no shortcut. We cannot do without them. Then coming to our equipment. Can we take the questions in the end? Yeah. Then coming to the equipment. I believe Coblation has the best hemostatic abilities for intraoral surgery of all the equipments I have used in my hand. Once you're cutting through major tissues with small vessels, you need a good hemostasis. Why you need a good hemostasis? It's not for later on. While you are extubating, invariably the blood pressure of the patient is going to go a little high. I'm sure every ENT surgeon would have experienced this. And that point of time, if there are tissues which are not properly coagulated, they tend to bleed. So, and then you also do not want edema. You do not want to use a lot of heat. You do not want to use too much of cautery on the tissues. So, if you do not have a good hemostasis while extubating, the patient will tend to bleed. And at that time, when he has already given the reversal of the muscle relaxant, you ask him to again give him, you want to again paralyze the patient. Your patient can go into complications of double, blockage and kind of things. So you do not want all those complications. So you have to have a good hemostasis. I'll just see, this is a palatal surgery. The other thing that you take care at this point of time, in UPPP, this is a classical UPPP, the lower part of the tonsils, they never come so close as to cause sleep apnea. It's only the upper part of the tonsil which comes closer. We had discussed that in our lecture on the other day. So there is no need to expose the tonsillar artery, and you can go intracapsular when you reach the lower pole. This will go a long way in preventing a primary and secondary bleeding from the tonsillar artery, because all the other arteries of the tonsil are very small. It's only the tonsillar artery which generally has a tendency to bleed, though there is a superior pole artery also. So if you have a bleeding from a superior pole artery, it's easier to manage rather than a tonsillar artery bleed, even in post-op period if you have to reintubate. Similarly, while doing base tongue, you have operated in a very, very deep area. I'll just run through this. So unless you have a very good hemostasis, while extubating, the patient may start bleeding. He may have a secondary bleeding. So you have to have a control over your surgical field in terms of bleeding. It has to be that clean, because the area we operate is really, really deep inside. See where we have operated. The area is really deep. It's not easily accessible if you land up with a problem of bleeding. Then this is my favorite video, because I keep on showing everywhere. You'll not get lingual vessels, don't bother about them, but muscular bleeders in the base of the tongue can be really troublesome. This is the most, this was one of the most frightening moments for me. It was my 8th case around 5 years back, and on table I got such kind of a bleeding. So be prepared. Now that time I was not wise enough, so see what is happening. I'm trying to control. It's a difficult area. I'm not able to control it. So finally, what I'm doing, come out, pack, pressure, and pray. Now that's not wise. So after this episode, flow seal is always in my theater. So if you have a situation like that, have a suction, put flow seal, and stop the bleeding. So flow seal. I still have 5 minutes.
We have transmitted this in the other hall. There are people who are sitting behind, can go in the other hall.
Okay. So Rajesh wants, why didn't you announce?
I can see people standing there. We've transmitted this whole session into the other hall also. So please be seated there. Sorry.
So if you anticipate that there is going to be bleeding someday, so have flow seal in your theater. So you can put a suction, put flow seal, and stop that bleeding. Anticipate this to happen in the post-operative period, 1 or 2 hours. You may have done a little faster work with coblation, and that can just open up if the blood pressure is more. So 2 things you can do. Extubate with nitroglycerin, NTG, nitroglycerin. Your blood pressure will remain under control. Your anesthetist will happily give a little bit of nitroglycerin drip, extubate, wait for some time, then till the patient is settled, then you switch it off, and there's no problem. Second thing is that if you are doing a big tongue-based surgery, do not extubate on table. That I'll come to in the next slide. So post-op edema of the tongue is one big issue. I have already talked in the tongue-based surgery, but this is such an important issue that I want to talk on it again. This does not happen because of cautery. This does not happen because of radiofrequency. It does not happen because of coblation. It happens actually because of the length of time that you have applied pressure on the tongue. So you have put in the mouth gag, you have pulled the tongue out, and you have opened the mouth gag. Tongue is a skeletal muscle. So if you compress the blood supply for more than 20-25 minutes, it will start undergoing ischemia, and that ischemic changes will lead to edema. So do not let the tongue get strangulated for more than 20-25 minutes. You relax, release the mouth gag, let the tongue go inside, wait for 2 minutes, and reapply a mouth gag. This problem will not happen most of the times, unless you have gone inside the tongue and really done a lot of cautery or radiofrequency. So post-op immediate bleeding you must be thinking about, and therefore you can do a multi-level surgery in single stage. We discussed about that. You can do stage surgery in which you do nose first followed by palate and tongue base, because if you block the nose in the post-operative area, if you are not blocking the nose, it's still all right. If you are doing a nasal packing or a major surgery on the nose, then the patient will have to breathe through mouth, the tongue will fall back, and you'll have a very, very difficult time extubating the patient. So it's better to stage the patient, do the nose surgery followed by the palate and tongue base. I'm talking of big tongue bases, I'm not talking of very small tongue bases. And you can extubate immediately. You know, now you're wise enough to know all the criteria, AGM, base monitoring, all those things before extubating. Big tongue bases, still, I would never extubate on table big tongue bases. They can turn bad anytime, and one case in your lifetime will keep on haunting you, and it will prevent you from working further. So no harm in doing either a tracheostomy. If you're not sure, if you do not have the facility, do a tracheostomy, bypass it, or keep the patient in the ICU with nasal intubation for 24 hours. That is the safest. You do not have to do a tracheostomy, additional surgery, and there's no harm in keeping the ICU for 24 hours. It makes your life very simple. You're not stressed. Patient's relatives are not stressed. They know that he'll be in the ICU and next day he'll be coming. And 24 hours do not make a difference in anybody's life, but you'll never have a problem of bleeding pre-op, in the immediate post-op. And next morning, if you require, if you're not sure, you can put a small flexible from the other side. This is the endotracheal tube. This is the Ryle's tube. You can see your larynx, you can see your base tongue. There's no bleeding, there's no edema. Then ask the patient to open the mouth, take out the tongue. The patient should be semi-sitting, opening the mouth, showing you the tongue. That means the patient is fully out of anesthesia. There's no sedation. And that's where the obstructive sleep apnea is gone, because the patient is not in sleep, not in anesthetic agents. And that's when you can safely extubate the patient. Even if there's a bleeding at that point of time, at least the patient is awake, he will spit out blood. You make arrangements, you give blood, then take him to the theater, if at all that happens. After 24 hours, generally it will not happen, because the primary bleeding time is gone. So I thank you very much for your time, and I hope you'll carry a lot of lessons from this conference to do a safe surgery on sleep apnea. Thank you very much.
Thank you, Dr. Vikas. I call upon now Dr. Claudio Vicini for Dr. Mohan Kameshwaran oration, Future Perspectives in OSA Surgery.